Throughout my professional journey, I have always prioritized the health and well-being of the patient. So I'd like to share with you experiences that demonstrate the benefits of visualized endometrial sampling over blind curettage or biopsy. In this example, we'll take a look at a case that illustrates the benefits of visualized sampling to provide the opportunity to confirm that pathology has been completely excised. This case is a 46-year-old who presented with abnormal uterine bleeding and a very large 24-centimeter fibroid uterus. She ultimately did want to proceed with hysterectomy, but we did recommend endometrial sampling because of her risk factors for endometrial hyperplasia and malignancy. So she had an office endometrial biopsy, which unfortunately was not successful due to obstruction from fibroids. And this is one of those really frustrating situations where the patient has gone through a painful procedure in the office, but is now having to go through a second procedure because we have not completely gotten a sample and not made a diagnosis to proceed with the next step in treatment. So in this case, we did do a hysteroscopy where we actually were able to enter the cavity under direct visualization, ensuring that we were not going to miss anything and also ensuring that we were going to complete the sampling without having obstruction from the large fibroids. You can see in her case, there were multiple reasons that hysteroscopy was beneficial. One, a very large cavity, which we wouldn't have been able to sample accurately with a blind biopsy. Two, obstruction from fibroids, not even be able to enter the endometrial cavity. And then three, atrophy because of her medical therapy. So because of all of those reasons, this patient's a perfect candidate for having a visualized DNC where we're doing the sampling under direct and continuous visualization with the MyoSure device. That way we know that we're able to enter the cavity, confirm that we're removing the correct tissue, and also getting enough tissue to make an accurate and timely diagnosis so that she can proceed with the definitive treatment of hysterectomy in the long run. So in summary, when you have a patient who you think is going to have a high risk for sampling failure, it may be better to avoid a painful procedure in the office that we know has a high chance of not being successful due to obstruction from fibroids, an atrophic cavity, or just having a really large cavity in which you're not confident that you're sampling the entire thing. And this is a great case to demonstrate that.